Hi everyone, Professor Davis here, and we are going to dive into the reproductive system here in medical terminology, and we're going to have to actually do this in two parts due to how long this chapter is, looking at all the different things, because you have to separate the male reproductive system and the female reproductive system when we're talking here. The other systems, there was really no difference between male and female, but here there is, and so that's what we're going to see is we're going to have to do a kind of a separation because we have to cover so much of that information along with what the reproductive system does. So we're going to start first with the female reproductive system. When we look at the female reproductive system, you do see that there are going to be kind of two components that go along with it. You have the external genitalia and you have the internal genitalia. So looking at the external genitalia, you have the structures that are going to make this up, okay, leading to what we call the vagina, which is the entrance into the internal genitalia of the female. So you have the pons pubis. This is going to be a pad of fatty tissue, thick skin, overlying a bone called the pubic symphysis. So where your two hip bones come together, there's going to be an area there called the pubic symphysis. This is going to be right kind of below that. Now, after a girl goes through puberty, we do see that this area does become covered with hair. We then have the clitoris. This is a small mass of erectile tissue, has a lot of nerves in it, and it has the similar structure. We would call it like a homologous structure to the penis in males. This small mass of erectile tissue becomes erect in response to sexual stimulation in females. There's two pairs of skin folds that are located here. You have the labia majora and the labia minora. These both protect the vaginal opening, and so we do see that they are going to kind of engulf each other. So the larger ones obviously are the majora, and then the inner ones that are smaller are going to be the minora. Now, the labia minora merge to form a hood. Okay, so they kind of come together up in the front, the anterior part, and they form a hood that the clitoris then is behind. We also see that there are some paraurethral glands that are on each side of the urethra. This is going to go along with the vestibular glands that lie adjacent to the vaginal opening. And these glands do produce and secrete a type of kind of mucus or substance that is going to help with lubrication. It also is going to have things that are going to help with potential invading foreign objects, like when we talk about bacteria or viruses or fungus. It's all going to have a kind of pH and stuff to help with some sort of protection. There's also an area called the vestibule in here, and this is going to be any space between the entrance to a canal. So the vaginal vestibule is the space between the two labia minoras, which are going to encompass the urethra and vaginal openings. The greater vestibular glands, also known as the Barthane's glands, produce a mucus-like secretion for lubrication during sexual intercourse. An important location term here is the perineum. It says the area between the vaginal opening and the anus. So this leads up into then the female reproductive organs that we would consider are the internal genitalia. So they're inside of the body. These are going to include the ovaries. There's going to be a right and a left ovary. You have one on each side. These guys are going to be really important because they're going to be where the production of the ova or the egg takes place. The ovaries also produce a lot of hormones for the female's body. So things like estrogen, progesterone, those are going to be produced by the ovaries. So these are known as the female gonads. We also see that the ovaries are about the size of about an unshelled almond, so they're not very large. There is going to be a tube that is going to not touch, but come close to the ovary. So if the ovary is here, this kind of tube kind of hangs out over it like this. This is known as the fallopian tube or the uterine tube. This is going to be what pulls in the egg when it is released during ovulation. It's going to then take the egg and allow it to travel down its tube towards the uterus. This is the main place where fertilization is going to take place. And so we do see that the inside of the fallopian tube, there's little fimbriae, and these little finger-like extensions sweep and move the egg forward towards the uterus. And this takes about 5 to 7 days to move from the ovary to the uterus. Now, the uterus itself is a muscular organ, and it prepares to receive and nurture the fertilized ovum. It's going to have a special lining around it. It does have a pear shape, and it is hollow on the inside. This is where implantation of a fertilized egg would take place, and the baby then would develop and grow in this structure. Since it is a pear shape, that narrow part of that pear is going to be the area where there's an opening to the vagina. This is known as the cervix. The vagina is commonly called the birth canal. It is muscular and it is capable of sufficient expansion, okay, in order to allow the child to be birthed through that canal. It also serves as the repository for sperm during intercourse. So this is where the sperm is going to be deposited, and then the sperm has to travel to try to find the egg. All right, when we look at this, guys, one thing too is when you see uterus, you see utero or hystero, meaning uterus. There's a third combining form, which is metro, which also means uterus. We may use this a lot of times when we talk about like menstruation. So we'll talk a little bit more about those combining or word parts in a minute. The uterus does consist of 3 layers of tissue. From the outermost layer to the innermost, we do see that it is the perimetrium, the myometrium, and the endometrium. So the outermost is the perimetrium, the middle is the muscle part, and then the inner is the endometrium, and that's the part that gets shed during each cycle. So it builds up to prepare for the egg implantation. If that doesn't occur, that's shed and it starts back over again. All right, so this kind of gives you a rundown of the external genitalia in females and the internal. So let's go and look at our word parts that go along here with the female reproductive system. So we have gento, which is going to be for genitals. This is going to be the organs of reproduction. We have cervico, which is neck, and this is known as our uterine cervix. You have culp or vagino, which is going to deal with the vagina. Hystero or utero for the uterus. Metro or measure, which is the uterine tissue. That's why it's called the endometrium. Oophro or ovari, which is for ovary. Salpingo, which is the fallopian tube. Perineal, which is perineum. Vulva, which is vulva. Lapro, which is going to be dealing with the abdominal wall. Meno, which is mouth. Oo, which is going to be eggs. We call it an oocyte. It's going to be an egg. Topo is place or position, and tropon is that which stimulates. All right, and so these are going to be some terms that you're going to see as you go through your chapter looking at the female reproductive system. Now, also looking at the female reproductive system, we have to look at the fact that there's an ovarian and a uterine cycle that's taking place. These are happening simultaneously in a woman's body, and so we do see that we have to see what's going on with both of these. So during much of a woman's life, the endometrium goes through this monthly cycle where it has to grow and build, and then it gets discharged through that menstrual cycle where we get rid of it so we can rebuild new. These are the reproductive cycles. They normally occur in females from shortly after they have their onset of puberty. We call that menstruation. It's the first time that they are going to end up going through that process. We call that the menarche, which is the first time that they go through the process of menstruation. This continues all the way until it stops with what we call menopause. Menopause is the end. It's not going to continue, and so we don't see this process happening anymore. The secretion of female reproductive hormones follows also this monthly cycle, and it has a pattern, and it affects how the uterus and the ovaries are going to act in these cycles. Together, these cycles again are called the ovarian cycle and the menstrual or uterine cycle. The ovarian cycle reflects the changes that occur in the ovaries themselves, okay? So when they go through the process of allowing an egg to be chosen and it matures and then it creates a follicle, the follicle ruptures and ovulation of the egg or the release of the egg takes place. That's all with the what we call the ovarian cycle. And then the uterine cycle is going to be what's happening in the uterus, okay, where we build up the uterus, we shed it off, that sort of thing. Now, both are working together because the egg being fertilized would implant into the uterus. So the egg being produced in the ovary will eventually end up in the uterus, and so this is why these cycles go together. Now, the onset of puberty normally occurs in females between the ages of 9 and 13 years of age. We do see the development of breasts that happens with this, as well as that first menstruation cycle that takes place. The female reproductive cycle begins again at puberty, and it continues for about 40 years. We see that menopause tends to happen in like the mid-late 50s for the most part. Sometimes it's a little earlier, sometimes it's a little later, just like the start of puberty may be earlier or later. We do see the external characteristics of sexual maturity start to come into place. You have female adult distribution of hair. We have development of the breasts, as well as the labia starts to have hair that covers it. It gets a little more enlarged. So we do see that this is going to start to happen in females as they go through the process of puberty. So menopause, also called the climacteric area, is going to be where there's a natural cessation of the reproductive cycle. So menstruation stops, hormones also start to decline. Menopause may occur earlier due to like an illness, or if we have surgical removal of the uterus or both ovaries, this may also occur. So the hypothalamus, which is part of the brain, is going to help control this whole process. It's going to talk to the pituitary gland, which is located beneath it, and it's going to cause the pituitary gland to secrete some hormones. These play a significant role in starting the reproductive cycle in females, allowing for menstruation to begin. These hormones produced by these structures act on the ovaries, causing them to produce egg, but also causing them to produce two hormones themselves, which is estrogen and progesterone. Okay, we also see that we have the oogenesis, which is the formation of egg, and then we have ovulation, which is the release of the egg. And again, menses is going to be part of that menstruation that takes place. All right, so again, these are terms that go along with the uterine and the ovarian cycles. Let's take a little bit of a look at what's happening during the month of an ovarian cycle and a menstruation cycle or uterine cycle. So in the ovarian cycle, days 1 through 5 is where the follicular phase takes place. This is the growth of the follicle within the ovary. This is where a certain particular egg has been picked. It's going to continue its maturation through meiosis. It's going to grow, and then we see that it also is going to start secreting estrogen. Estrogen levels start to rise, and this continues through the process of ovulation. So days 6 through 12, the follicular phase continues, and it depends on the woman of when that ends. But normally day 13 to 14 is when ovulation takes place. So the ovum is released. The follicle actually ruptures, and some women say that they can even feel when ovulation takes place. When the egg is released, we do see that this is the luteal phase. The egg now is going to travel through the fallopian tubes towards the uterus, but in the ovary itself, the follicle actually starts to collapse on itself, and we call this the corpus luteum. This now is a structure that's going to release a different hormone, which is called progesterone. Progesterone continues to be high until pregnancy is detected. If pregnancy happens, it stays high. If pregnancy does not occur, we see that the progesterone levels then drop off, and we start the ovarian phase again. In the uterine phase, these are happening at the same time as what's happening in the ovarian phase, but in days 1 through 5, we call this the menses. This is where the blood is shed through the vagina, and we're cleaning out that layer in the uterus. Day 6 through 12 is the proliferative phase. This is growing the new layer, the endometrium, allowing for implantation to then occur. Day 13 to 14 is the proliferative phase may continue. And then day 15 through 28 is the secretory phase, where we see continued growth and secretion of glycogen, getting ready for implantation. So if implantation took place, the uterine and the ovarian phases would then cease, because the hormone levels would then change due to pregnancy being controlling the hormones versus the other part of the body with the hypothalamus and the pituitary gland. All right, so this brings us to the gynecological examinations. So females have to go through this process. We do see that it's going to consist of kind of 4 main parts. The first is an inspection of the external genitalia. So they're going to take a look at the external genitalia, what it looks like, how it's going, if there's any kind of lesions or any problems there. Then they'll do what we call the speculum examination. Now, a speculum examination is going to be where they actually put in an insert what they call a speculum that then spreads open the vaginal walls and the cervix so that can be inspected. Now, this is also when they're going to collect something called a pap smear. Pap smears are for cytologic examination. So this is to look at certain cells. Pap smear is an abbreviation for the Papanicolao test, and so we call it pap smear for short. This is going to be where they actually go in and they take a little kind of scraping of cells off of the cervix itself. This is going to be collecting this in order to then look to see if those cells are normal or abnormal. This is where we can detect cervical cancer. And so that's why we would end up doing a pap smear. So they're going to end up taking some of the cells off. Sometimes it's even kind of using like a little pinch tool to pull a piece of the cervix off in order to take a look at it on the cell side. We also see that there's going to then be a bimanual examination. This is going to assess the location and size and mobility of your pelvic organs, and so the doctor will use their hands in order to locate and palpate the uterus as well as the ovaries and that sort of thing. And then the fourth is the rectovaginal exam. This one is going to be where it's not always performed. It's only if they notice something that is not quite right and they can't access part of those organs. This is going to evaluate the posterior aspect of the genital organs and the rectal tissue. It can also check the area of the vagina behind the cervix. And so it's just another way to take a look. Now, when we talk about those cytological specimens like the pap smear, this is going to be where, again, they send it off and they're going to then get it looked at by a pathologist. They're going to look at the number of cells. How are they growing? What's the shape? They're going to look to see if there's any what we call dysplasia, where they're growing in a different way, in a bad way. And that's going to be letting us know if it's cancer or precancerous that's taking place. It's standard practice to grade the pap smear where we say it's a class 1, 2, 3, 4, or 5. Class 1 is when it's normal, but class 5 is definitely cancer. So you have stuff in between those two. Most physicians recommend having pap smears done on a routine basis. Used to, it would be every year. Those rules have kind of changed based on how we are able to look at mutations and genetics now, but there's still a routine that takes place. If they detect any issues or things that are abnormal, you may have to do these kind of tests more often. We also see that they can do the presence for microorganisms. This is going to check a lot of times for an STD or STI, a sexually transmitted infection or disease. So they can end up doing a collection of the fluid and then going through the process of growing that in the lab. So they can look for trichomoniasis, which is a vaginal and urethra parasite. They can also do gram staining and look for certain bacteria like gonorrhea. And so there's a lot of things that they can do with looking for bacterial or fungal infections using cultures from the fluids that have been collected during these types of exams. We also see that they can also do an endometrial biopsy. This is meaning they're going to go deeper in and they're going to take a biopsy of the endometrium, which is the inside part of the uterus. And again, this can help us look and detect potential cancer or cells that are growing in a different or difficult way that we would consider, again, a form of dysplasia. So some diagnostic tests when we're looking at this for female, we can have a colposcopy, which involves the use of a low-powered microscope to magnify the mucosa of the vagina and the cervix. This instrument's used to look for suspicious cervical or vaginal lesions. We can also do a hysteroscopy. This is a direct visual inspection of the cervical canal as well as the uterine cavity. This uses an endoscope, like a camera, to pass through the vagina. This is performed for several reasons. It could be for the excision of cervical polyps, so they notice there's polyps growing and they want to take some of those off. It could be a collection for some biopsy for tissues in order to do a biopsy, or removal of an intrauterine device like an IUD or something that's been put into the uterus. Hysterosalpingography. This is a radiological examination of the uterus and the as well as the fallopian tubes. It's after they put an injection of a radioplaque material into these organs, and then they can actually take a picture of it, seeing the size, shape, and position of the organs. This will help them also detect if there's tumors present or other things that are abnormal, as well as if there's an obstruction in the uterine tube. We can also do a rapid plasma reagent test, or an RPR. This is a blood test to detect and monitor syphilis, which is a sexually transmitted disease. We'll discuss those a little bit later in part 2, but this is a type of blood test that can help detect that one specifically. Human chorionic gonadotropin is going to be also known as HCG. This is present in body fluids, specifically like urine and blood, when pregnancy takes place. And so we do see that those little pregnancy tests where you pee on the stick, or collect some of your urine and you place it into the little device, those are going to be where they are detecting this particular hormone. This is going to allow us to know if a pregnancy takes place. It is what is released from the chorion, which is a membrane that is around a developing embryo. Okay, and so that's what you're looking at for some of these diagnostic tests. All right, so let's talk a little bit about some disorders or pathologies in the female reproductive system. And so the first group here are the menstrual disorders. These include heavy or irregular flow, spotting, absence, or skipping of periods that can take place. This could also be painful menstruation or premenstrual syndrome. And so we're going to take a look at a few of these. We have first amenorrhea, which means either a normal menstruation or too profuse menstruation. We then have menorrhagia. This one is going to be looking at normal menstruation or again, too much. So these are terms that can be used kind of interchangeably, whether it's just kind of normal or it's actually a heavier flow than normal. Metrorrhagia is a uterine bleeding other than that caused by menstruation. So if you're bleeding for some other reason due to like a laceration or a cut or something like that inside the uterus. We do see that it may occur as spotting or outright bleeding. The duration of the flow sometimes is being prolonged depending on if the hemorrhaging of the uterus continues. This can happen sometimes with uterine tumors, whether they're benign or malignant, and they can also occur with cervical cancer. We also have amenorrhea, which is absence of menstruation. This is normal before puberty, and it's also normal after menopause. And we also see that amenorrhea is also normal during pregnancy because you shouldn't have a period during pregnancy. However, amenorrhea can also occur sometimes due to like stress. It can happen due to certain medications or drugs that the individual is taking. And so it could ultimately be something that could be wrong as well. Underdevelopment of the reproductive organs or hormonal disturbances can also cause the absence of a period during puberty. When menstruation has begun but then ceases, that's where we use the word amenorrhea. Dysmenorrhea is a painful or difficult menstruation, and this is kind of common for a lot of women, especially if they have things like endometriosis or some other stuff that we'll talk about a little bit later. But these are going to be some of the menstrual disorders and what you would see with some of the terminology. Ovarian disorders. When we're looking at the ovarian disorders, you're going to see that you're going to see that a lot of that OO, because this is where we're talking about the ovaries. Salpingitis is inflammation of the ovaries and the fallopian tubes. We also see the orphoropathy. This is going to be a disease of the ovary itself. Another thing that can happen in the ovaries is polycystic ovary syndrome, or POS. This is a hormonal disturbance characterized by an anovulation, amenorrhea, and infertility. So it disrupts kind of the ovarian cycle and the uterine cycle. We do see this. It also causes an increased level in testosterone, which is the male hormone, which women still produce, but this increases the amount. Estrogen and luteinizing hormone is also going to increase, but the secretion of FSH is going to be decreased. This causes numerous cysts to develop on the ovaries, thus its name, because it's a polycystic, lots of cysts, and it does cause the ovary a lot of times to double in size, causing a lot of pain as well. Now, an ovarian cyst, this can be a globular sac. It's filled with fluid or a semi-solid material. It can develop on the ovary. Benign cysts are common, and they may even be asymptomatic, like you may not even have any symptoms. You don't even realize you have them. But sometimes they can also cause a lot of pelvic pain, and they can also disrupt the menstrual cycle. This type of cyst may be transient, like where it comes and goes, or it can be pathologic, where it's going to be tied to some other types of diseases. We then see ovarian cancer. This is the leading cause of death from reproductive cancers because it is usually spread to other organs by the time it's discovered. And so this is what makes it a little more dangerous because it's deeper. It's not something we test for on a regular basis. And so normally it's already malignant and spread before it's detected. Let's talk a little bit about some of the pathologies. And so cervicitis is going to be where the cervix is inflamed. We also have pelvic inflammatory disease. Pelvic inflammatory disease is where the whole pelvic kind of floor becomes inflamed. This can cause some major issues because it can cause scarring of the fallopian tubes, and it can even cause sterility issues or infertility issues in females. This is related a lot of times to untreated sexually transmitted diseases. We also can have an ectopic pregnancy. This is going to be where the egg, when it gets fertilized, instead of finishing its traveling down and embedding into the lining of the uterus, like where it's supposed to, it embeds in the fallopian tube and starts to try to develop into a baby. And when this happens, the fallopian tube doesn't have room, and so it can actually cause it, as it's developing, to bust the fallopian tube. We can then have hysteroptosis, and this is where there's a weakening of the ligaments and the stuff that in the pelvic floor that should be holding the uterus in place, and it actually causes the uterus to start to prolapse and fall out due to gravity. You can also have fistulas, which are abnormal openings from the vagina into other areas, say like the urethra, and so it causes there to be like a mixing that should not take place, and so urine gets into areas it shouldn't, and vice versa. And then you can also have a cystocele, which is actually when the bladder pushes into the area of the vagina, and it's kind of like herniating into an area it should not go. Now, this is not all of the disorders or pathologies that can be seen in the female reproductive system. There's a whole lot more in your book, but these are just a few. So let's talk a little bit about the surgical and therapeutic interventions that we see for females before we switch gears and talk about male reproduction. So when we're talking about the surgical and therapeutic interventions for females, you are going to see that we have colporrhaphy, which is going to be where there's a suturing of the vagina. And so this happens a lot of times whenever you have a hysterectomy and they take out the parts, they will then suture up the top part of the vagina. A colpoplasty is actually going to be a surgical repair of the vagina. Oophorectomy is going to be removing of the ovaries, and so you could remove one or you may remove both. Orophoropexy is going to be like if the ovary has lost its natural support and it's kind of like floating or moving where it shouldn't go. This is to go and anchor it and put it back where it needs to be. And then we have a vulvoectomy, and this is where they have to do an excision and remove the vulva, and this happens normally with vulvular cancer. All right, some other types of treatments we have are cryotherapy. This is also known as cryosurgery. This is a treatment that uses a sub-freezing temperature to destroy tissue. We may see them using cryosurgery or laser type of surgery in treatments of lesions that are going to be found and accumulated on the external genitalia, especially when we talk about genital warts. A common surgical procedure that is performed for either diagnosis or treatment for a miscarriage is known as a dilation and curettage, also known as a DNC. This is where the cervix becomes dilated to allow insertion of a curette into the uterus. The curette is a surgical instrument shaped like a spoon or a scoop, and it's used for scraping and removing the material of the endometrium. And so if a miscarriage takes place and it doesn't discharge like it's supposed to, the child has stopped developing, but the body is not getting rid of it, this may be done to help clean out the uterus to allow for pregnancies later, but to also decrease the chance of infections and things like that. So we do see it is used a lot of times to assess diseases in the uterus, to correct heavier prolonged vaginal bleeding, or to remove products of conception. So the next one is a salpingoscopy. This is making a new opening in the uterine tube. May be performed also for the purpose of drainage if a uterine tube is obstructed by infection or scar tissue. And so if scar tissue has built up, this would be like where they would reroute around that scar tissue. We then have a tubal ligation. This is one of several sterilization procedures in which both the uterine tubes are constricted, severed, crushed, tied. A lot of times we talk about tying their tube. So it used to be where they would actually like tie it up with an actual type of ligature, but now they don't necessarily do that. They a lot of times will kind of like clamp it down, and these can be reversed in some cases, and they can do this by making a new opening and restoring the pathway, but it's not always successful. It's not guaranteed that these can be reversed when you have a tubal ligation. So this kind of finishes up the female reproductive system. So now we're going to switch gears a little bit and talk about the male. So when we're talking about the reproductive system as a whole, we do see that it produces, stores, transports, and delivers things when we talk about the male reproductive system. In the female, we do see it also produces, it's going to transport, and then it grows. Okay, when we talk about pregnancy, and we'll talk about that in part 2. But in the males, we do see that it's going to produce sperm. It's going to help sustain and mature that sperm, store it In this process is known as the idea of maturation of the sperm, where we take those immature sperm, the spermatozoa, and we increase its ability to be more successful. It then is going to transport that into the female and deliver it, hopefully to allow for fertilization to take place. Another thing that this produces is hormones as well. So spermatozoa is the sperm. Spermatozoon is a singular sperm. These are going to be formed in the testes in the male, and these are known as the male gonads. And so we have a singular type. Look at that, where we call it the testis. All right. Now, when we're looking at the male reproductive system, we do have lots of structures that are present. You're going to work on labeling those in your book. But one thing that's important to note is that the testes have a very extensive tube network inside of them, as well as then leading out through the penis in order to deliver the sperm. And so these series of tubes are really important, and at different points they get different names. And so we do see that you have the tubes in the testes where the sperm starts, spermatogenesis starts. Then they're going to move to an area that's this comma-shaped structure inside of the scrotum with the testes. That's called the epididymis. This is going to be where maturation occurs for the sperm. The sperm, once it's matured and kind of gone through its quality control, it's going to then travel through the vas deferens. This is also known as the ductus deferens. It's a series of tubes that leads it to the seminal vesicle, where some fluid gets added, and it gets ready to then be loaded into the ejaculatory duct. Once it's in the ejaculatory duct, we do see some more things added to it from different glands, like the prostate. And all of these glands are going to help create what we call semen. And so it's not just sperm, it's going to be semen. It's like it has glucose, it's got fructose, it's got different pH nullifiers. There's a lot of stuff in there to help it hopefully be successful once it enters into the female. Once it's released through the ejaculatory duct, it's going to travel through the urethra, through the penis, and out into the female. Okay, ultimately, if this is through intercourse, it would enter into the vagina for delivering the actual sperm. The sperm then would then disperse and try to go find the egg. So we have lots of structures here that are going to help with that idea of transporting and delivering the sperm. So let's look at some of the male word parts that are present here. You have pino, which is for penis. Belin, which is the glans penis. We have the scrotum, scroto, which is scrotum. Orchi, orchid, testicular. Those are all talking about the testicle. The ilia is going to be pertaining to. Epididymo is the epididymis. Spermo or spermato is spermatozoa. Vaso or vaso is vesicle or ductus deferens here. Prostato is prostate, and semino is semen. And so we have some of these word parts here. And again, this is not all of them, but this is the majority that you would see for the males. So let's talk about some of the diagnostic tests and procedures for males. We do see that there is the digital rectal examination. The digital rectal examination is just like what you think it is. It's an assessment of the prostate gland as well as the rectum itself. The examiner inserts a lubricated gloved finger, a digit, hence the name of the procedure, into the rectum, and they look for the size and consistency of the prostate gland as it's assessed. Palpation of inguinal hernias. Recall that we've used the word palpation before. It's a technique in which the examiner uses the hands to feel the size, location of an internal structure, so they kind of feel around. An inguinal hernia is one which is a loop of the intestines that enters the inguinal canal, which is going to be like right in the growing area, where some of the muscles may separate and this part of the intestines protrudes through. In a male, an inguinal hernia sometimes fills the entire scrotal sac, though it can travel all the way down there. And so it needs to be palpated and looked for. We also have the prostate needle biopsy. A needle biopsy is going to be where they use, again, a small needle, and they go into the prostate and they're going to take out some of the tissue. This is to look for prostate cancer or if it is suspected. They may not know if it's there or not, but it might be suspected. In a needle biopsy, a small amount of tissue is removed. It's sent off to a pathologist. It's looked at in order to look at the cells to see if they are mutated or growing in a disorganized way. We also see for the prostate, we can use the prostate significant antigen or a PSA test. This is a blood test. It's used to screen for prostatic cancer and to monitor a patient's response to treatment if they do have prostate cancer. Elevated PSAs are associated with prostate cancer. We also see that sperm count is a test for male fertility. And so this is to measure the number of sperm, their appearance, how motile are they? Do they move very well? Are they good swimmers in a sense? These would all be things that they would look at from a collected sample of semen from the patient. Some pathology word parts we want to see here is going to be things like crypto. This is hidden. Ogo we talked about already in urinary, which is few, and varico, which is twisted and swollen. And so these are going to be helpful as we go into the next one, which is the pathologies in the male reproductive system. So some pathologies that we can see here, infection and inflammation examples are orchitis or orchitis. These are going to be inflammation of the testes. Epididymitis is going to be inflammation of the epididymis. Balanitis is going to be inflammation of the glans penis, so this certain covering part of the penis. Prostatitis is going to be, of course, inflammation of the prostate gland. And then we have benign prostatic hyperplasia. So when we look at benign prostatic hyperplasia, this can be abbreviated as BPH. This is a common non-malignant disorder, particularly in men older than the age of 50. Hyperplasia means there's an increased number of the organ. So the actual prostate starts to get enlarged. This creates problems though, because the prostate gland is a donut-shaped structure and the urethra runs through it. So if this organ gets larger and it starts to take up more space, it can actually kink up the urethra. This causes them to have an issue where they cannot urinate. They can't empty their bladder, and it causes a buildup to occur. A lot of times to go in, they're going to have to go in and shave off some of that tissue. They go in and they get rid of it. When they do that though too, they also send it off to make sure that there's not any prostate cancer that is present. Cryptorganism is a development defect that's characterized by the failure of one or both testes to descend into the scrotum. This is developmentally where the testes, as they develop in the abdomen, they should then descend down into the scrotum. This does not occur in this particular disorder. We also have hydrocele. This is a mass usually filled with a straw-colored fluid. For this reason, its name incorporates the combining form of hydro, which means water. In this term, hydro may help you remember that the swelling contains a straw-colored fluid. In a hydrocele, this happens in the scrotum. It may be the result of orchitis or epididymitis, where there's inflammation of the testes or the epididymis itself. Or there could be an obstruction in the vein or lymphatic ducts that are in the scrotum. Oligospermia is the next one. This means insufficient sperm in the semen. This would be an indication of fertility issues in the male if they don't have enough sperm detected. We also can see testicular torsion. This is when torsion or twisting of the spermatocord and blood vessels get twisted in the scrotum itself. The torsion of the testes is the axial rotation, so it moves around of the spermatocord and it cuts off blood supply to the testes. This can lead to loss of the testicle if it's not unwound, unkinked, and blood supply restored. Surgical correction within a few hours of the injury is required in most cases in order to save the testes. The varicocele, this one is a cluster of dilated veins that occurs above the testes. When we look here, it also is talking about kind of a twisted or swollen with its word choice with the varico. In many cases, varicoceles are asymptomatic, but they can contribute to infertility, and so they do need to be looked at and monitored if they're present. Last but not least, in this part 1, we're going to talk about surgical interventions for the male reproductive system. So we can have a hydrocelectomy. We talked about the hydrocele being a fluid-filled sac that's in the scrotum. A hydrocele, if it happens in a newborn, may resolve itself spontaneously, but in adults, the hydrocele may become large and uncomfortable, and so it requires surgical incision of the scrotum to remove it. All right, and so this could be where they take it out, they release the fluid. It's a temporary measure, and it could induce infection though, because you're opening it up, and so you have to be careful of when you do this, but it's normally going to be done if there's a lot of discomfort. A hydrocelectomy is a surgical removal, and so it, like I said, it does increase the chance of infection. Orchiorrhaphy is the next one. This is a suturing of the testicles. Orchopexy is a corrective surgery, especially for that crypto torquidism we're talking about, where it's that bringing down the testicle. So if it didn't descend, it would be where they'd go in and they'd bring it back down and put it where it needs to go in the scrotum. We also can see a transurethral resection prostatectomy. This is known as TURP, TURP. It may be necessary to correct an enlarged prostate, especially if we are seeing that hyperplasia that takes place. They'll go through the urethra in order to do this. And then we also have the vasovasectomy. This could be used to correct an obstruction or a blockage in those tubes we talked about in the testes, but this could also be what they do to reverse a vasectomy. And so vasectomy is going to be where it's kind of like tying the tubes in the female, the tubal ligation. It cuts the tube so that the sperm has nowhere to potentially go, hopefully to prevent pregnancies. The vasovasectomy is going to be to help reverse this. So not only is it going to be where it's to bypass or go around an obstruction if it's already present, it's also then to potentially reinstate or reverse a vasectomy. All right, so this finishes up part 1. In part 2, we'll continue on and we'll talk more about pregnancy and sexually transmitted diseases. If you have any questions, let me know.